Hello, this is Video Journal Unit 3. This is my experience with a 57-year-old inpatient admit. She has a history of bipolar 1 diagnoses and also perhaps some underlying trauma that needs to be discovered. She arrived at the ED voluntarily endorsing suicidal ideations, and she had a definite plan, which was to use a blowtorch and Vaseline to set herself on fire. She does have a history of self-harm by cutting. She currently lives with her grandchildren, so she has a few granddaughters and grandsons. They all live in the same house, and patient has history of cocaine use but has been abstinent for the past 3 years. And the patient reported that she has concerns that she may relapse because her grandchildren smoke marijuana daily, and that seems to be a trigger for the patient for her own cocaine use. Patient endorses auditory hallucinations, but I think a little bit on sort of like further investigation, I disagree on that. She repeatedly, as per her auditory hallucinations are nothing but her sister's voice replaying in her head, demeaning her. So there are certain ways her sister would talk to her when she was younger, and insulting her and demeaning her and devaluing her. And she says that those phrases, those terms keep replaying in her head. So to me, it is some sort of a perceptual disturbance because she reports, quote unquote, hearing her sister's voice in her head, but I do not think it is truly an auditory hallucination. Patient appeared, she has a rather sort of style of rapid speech, where she talks in a very staccato manner. She speaks rapidly and then she pauses. Her eye contact kind of is flitting. Sometimes she does maintain eye contact, sometimes she does not maintain eye contact when she's answering our questions. She does not disclose any kind of motor agitation in terms of tics, tremors, EPS. Her gait is normal. Her mood, she reports that she is being anxious. Her affect was also slightly coherent with her mood. She was irritable, she was anxious at times, but she did answer all our questions, and she had this tendency of sort of demeaning, or kind of like, if the provider agreed with her, she would instantly reward the provider with suddenly idealizing the provider. And if there was a provider who was trying to educate her in terms of medication use side effects, which she did not agree with, she would instantly talk disparagingly, insultingly towards the provider. So she had this habit of kind of waving back and forth between I suddenly like you and I suddenly dislike you. So I think based on that observation, she does have some amount of borderline personality. She did mention that her husband died suddenly due to brain aneurysm. That could be an incidence of trauma that has not, she did not get an opportunity for bereavement, that has left a mark on her, or she could have further additional trauma from her past, which needs to be discovered. She does attend the group therapy sessions. We can refer her to individual therapy just to investigate this aspect of trauma a little bit further. However, we have started her on Zoloft 50 milligrams for now. And we've also given her 50 milligrams of Seroquel at bedtime to help her with sleep, because she did complain that her sleep has been poor due to the voices that she hears in her head. Patient has been doing well in terms of appetite, and she's very clean, likes to maintain a decent amount of self-hygiene. She keeps her room very clean. She's been very appropriate with the staff, no agitation, no aggravation. Currently, she still endorses suicidal ideation, so that is something we're going to monitor, see how Zoloft works with her mood, and reassess her for mood and suicidal ideation in a couple of days.